So, we've had a number of new therapies come through and combination therapies for multiple myeloma, which is great. But what we're still seeing is that for patients who's become refractory to the broad classes of drug, like proteasome inhibitors, IMiDs, and CD38 antibodies, they still have very short progression-free survivals and not a lot of treatment options. So that's a space where we really need new innovative therapies. We are also continuing to look for opportunities to improve response rate and durability of response for patients with high-risk cytogenetics. So myeloma with known genetic features that seems to make them resistant to the more conventional chemotherapy agents. And this is where we've seen a lot of excitement, for example, with CAR T therapy. Currently in the trial data that we've seen so far, these are the type of patients that are getting CAR T treatments, and the response rate has been quite high across a number of different CAR T products and appears to have some meaningful durability of response as well. So there could be a lot of utility for this treatment in the multiply refractory patient population, and these treatments include patients that have had high-risk cytogenetics. So, and these patients appear to have response as well. So we are awaiting to see if these different immunotherapy approaches could have a utility in this patient population as well. Another thing that would be interesting to see is there are certainly other immune-based approaches, such as bispecific antibodies and even antibody-drug conjugate. And currently, we've seen some emerging data with those treatment modalities that are actually targeting the same plasma cell or myeloma cell antigen, BCMA. And so, what are the roles for these treatment modalities in myeloma if they could all potentially be coming to practice around the same time will also be of interest.